fibrillation. Altered mental status protocol, glucoscan, D10 if they're hypoglycemic, Narcan, thiamine as needed by your judgment. If they're hypertensive, assume a bleed, don't attempt to lower pressure in the field. Transport emergently, code 3, if there's less than 8 hours onset of the following symptoms: aphasia, facial droop, unilateral weakness or paresthesia, inability to understand or verbalize, loss of vision in one eye or visual field, vertigo, sudden onset, persistent, progressive with headache. Or went to bed normal and woke with symptoms, although we don't know, we didn't used to know, we didn't used to transport that emergency. We now do that. That goes to the intervention hospital, because a lot of those patients we will take to intervention. And a lot of people wake up because of their onset of symptoms, turns out. Notify facility of a code 3 stroke. The emergency physician now will, at least at Southwest, will see the patient quickly in the room on your gurney, make the choice. This is a neuro 911, and it will go directly to the CT scan on your gurney. You will push them down there, put them on, and then you're gone. If he says this is not a neuro 911, the patient goes onto the bed in the room, and you're out of there. Now, patients meeting stroke and CVA criteria will be transported as per this. Symptoms 2 hours or less can go to the closest stroke center or to patient family choice. However, patients older than 80 will go to Peace Health Southwest, because they cannot get routine TPA. Symptoms more than 2 hours should go to Peace Health, because those patients will likely not get, will likely go, more likely go to intervention. Suspected intracranial hemorrhage of any duration goes to Peace Health. That's where the neurosurgeon lives. If the patient exhibits, and this is the change, if the patient exhibits signs of profound paralysis, can't raise their arm, can't raise the leg, aphasia, or is comatose, transport those to Peace Health. Dr. Mocht said to me several months ago, why don't we take all patients to Peace Health? And that would be the simple answer, but we live in a world of politics, don't we? No. It may come to that because Legacy is working on developing these, on managing these criteria of profound paralysis too. So, now the receiving stroke team, remember, they require more medical history from the patient's caregiver. It would be nice if the caregiver is there at the time. If they can be transported with, so much the better, but they need to arrive as quickly as possible. If not, get a phone number that works, that we can, that the hospital can talk to the family member or caregiver. Any particular heartburn about that? Now, here's a couple of changes in ALS assist protocols. Now, properly trained EMTs are allowed to assist paramedics with the performance of the following procedures while on scene. Now, and properly trained means we do have protocols, we do have training set up to train them in these things, and they have to have gone through these before they can say, yeah, I can do these. That's not your individual responsibility, that's the agency and department's responsibility. They can place 12-lead EKG monitoring electrodes. They may also, if they're in the and there are some more rural areas where perhaps District 10 would get there before, well, actually it would be more. In parts of District 3, EMTs will get there before, they're not 100% ALS yet. So District 3 may get there several minutes ahead of an ALS ambulance or the other ALS crew, depending on where that is. Same thing for Clark County Fire and Rescue. If the EMT may run that 12 lead to a place, so I'd like to see a 12 lead on anybody complaining of non-traumatic chest pain. You know, I don't care if they're 12 years old. If they're having chest pain that makes you think, well, this could be cardiac, I suppose, but they're too young. No, get a 12 lead. What does it hurt? And you never have to say you're sorry, and you don't have to say you're sorry in my office. Get it. If you got chest pain, get it. If you think cardiac. So I want the EMTs to think that they can put the 12 lead on and run it if you're going to be 10 minutes away. And they can call you and say, hey, you know, I think I got a STEMI. Or when you walk in the door, here it is. It's already in the protocol. No, it's in the state protocol. It's been in the state protocol for 15 years. No. So, paramedics can, or EMTs can, at your instruction, after they've been told, after they've been instructed how to, you can say, hey, start this IV, spike the bag. They can determine blood glucose determination via finger stick. North Country EMS and Fire District 13 and 10 have King Airways. And an EMT can place a King Airway. In the rest of the county, EMTs are currently placing iGels. We're training most in our protocol to do the high intensity CPR and the pit crew CPR. The EMTs have been trained to place the iGel. We're working on training a bunch of trained monkeys to place the iGel. It works probably too. iGel is a great device that works easily. Doesn't interrupt and the medic can stay busy. They can give intranasal Narcan if we've been trained at your instruction. They're not carrying it themselves, but they can use it. If they've been trained to the intranasal Narcan, my God, we're training patients at home to give, persons to give Narcan to their, quote, loved one who goes down with it. As a matter of fact, here's the thing. IN naloxone. I'd rather have the EMT use intranasal Narcan because it avoids a sharp. There's too many sharps lying around. But for the home kits, there's a Narcan auto-injector, which you can get, which now your friends and neighbors can have, knowing you're the happy junkie and sometimes aren't a very good chemist, and go down and they can use the Narcan auto-injector, which I haven't seen the price on it yet, but I imagine it's somewhere around $400. Now, there is limited immunity for, right now in our law, for people who seek medical assistance in a drug overdose. So if they call you and say, I think my friend, we encourage them to call and say, I think he overdosed, because they can't be prosecuted, and nor can the person who overdosed. So the only time I want EMTs to use Narcan, and we have in District 3 now and in Clark County Fire and Rescue trained EMTs to use IN Narcan if the paramedic's not there, because they get there before the paramedic, and there's no reason to have someone go 5 to 10 minutes who is depressed respirations, apnea, and/or hypotension. So we treat altered level of consciousness, unresponsiveness with depressed respirations only and hypotension only. So they have to have major symptoms of an overdose. They may or not have pinpoint pupils depending on the drug. If there's simple intoxication with narcotics, if they're just loaded and they don't have respiratory depression, they don't need to be treated by the EMT. I don't want my Narcan used for that. It's expensive for us as well, plus it's unnecessary. You don't want to get him, wake him up and become a raging withdrawal case. Paramedic will titrate that as needed. Okay, a couple of other things. We changed newborn resuscitation to fit the American Academy of Pediatrics Neonatal Resuscitation Program and the American Heart Association, which says basically, unless a baby, even if a baby has meconium staining, unless they're having respiratory distress, you don't really need to do much about it. That's the bottom line. So our protocol has changed to only read, if thick meconium or secretions are present and signs of respiratory depression, depressed muscle tone, and/or heart rate less than 100, then you can intubate and suction the trachea. Otherwise, even with meconium staining, most kids, they can have meconium staining, and if they're breathing normally and acting normally, no big deal. I already mentioned this one. Pain control with painful muscle spasms. You don't have to call medical control for concurrence now. You can give it on my orders. It'd be nice to titrate the Versed up to, don't bring him in totally stoned. Okay? Status asthmaticus for adults, even, I have added epinephrine 2 to 10 mics per minute drip. Going back to the good old days. We do it already for pediatrics. For status asthmaticus, I'd rather not have people die of status. Now, status means that they're not responding to your regular treatment. You're already doing all the things you're doing, plus you've probably given them magnesium, and you've got them on a continuous med-ned, and you give them Solu-Medrol, and you give them everything else. Put them on a drip and see how that works. Now, you've got them on a monitor anyway. Seizures, measure motor. Versed, 2.5 to 10 milligrams IV or IM until the seizure stops. Child, 0.1 to 0.2 milligram per kilo IV or IM. Slow IV push. May repeat times 1. So it means you can repeat the Versed. Newborn volume resuscitation, I think we had an error in thing. We corrected it. That's newborn volume resuscitation is 10 cc's per kilo, not 20 for pediatric. So we made that correction. Now we're having a continuing conversation and confusion and issues with legal blood draw. House Bill 1276, which I think went in 2 years ago. I think it's a year and a half ago anyway. And then was amended again this year. It's legislative amendment to rules pertaining to impaired driving because they had to stick marijuana and other drugs in there. So this is to increase the availability of forensic phlebotomists so that offenders can be appropriately and efficiently identified. That's a nice way of saying we need ways to catch people who are drunk and stoned because they don't have a breathalyzer for marijuana. So you can only do it by a blood draw. They made it so it was not professional misconduct. You cannot be sued. It's not a problem. for an advanced EMT or paramedic licensed, well, they forget you're not licensed, you're certified, but this is the same thing in the state of Washington, to collect a blood sample without a person's consent. So you can collect a blood sample without the patient, without the person consenting to it, if withdrawing blood was directed by a law enforcement officer for the purpose of a blood test under the provisions of a search warrant or exigent circumstances. And the exigent circumstances are no different than they used to be, and I'll get to that in a minute. However, they added that a person could do a voluntary consent at the request of police at the scene. So we've made a little change. Now, this is their special thing, and I can't read that any more than you can, because we had to. This is what the state police have. And these are the special things where they can ask you, and it's no different than it used to be. They could ask you to draw blood. If the patient was unconscious and there was an accident involving severe injury or death, if the patient's unconscious, or if they're under arrest for vehicular homicide, and they have it in Spanish, so you can read that too. If they're unconscious and you believe that they were driving and the policeman believes they were driving under the influence, of course, if they're unconscious, they're already a patient. So you already have presumed consent to start an IV, and you have presumed, and then you can draw blood. Okay? They're going to be a patient. If they're a patient, there's never any problem with you drawing the blood. If this is a felony DUI, and that is a special thing now, a felony DUI means that someone is there's been a severe accident, or maybe they're stolen a car while they're drunk, or there's a felony besides the DUI. Or, I like this one, felony physical control. But they have, this is all done for the state police, and I'm presuming that the locals will do it too, with little check boxes. Or this is a vehicular assault. That's no change. We always had that. So they're under arrest. Or this is a DUI arrest resulting from an accident with serious bodily injury to another person. So they can ask you to draw blood in any of those cases, but remember, they all said they were under arrest, essentially. Or you can, they'll tell you, we're going to draw your blood whether you want to or not. Do you want to consent to that? At the scene, if they consent, say yes, then you do a blood draw. The police have to have the equipment for you. You're not carrying it yourself. You draw it, and you draw it under the rules, which are, you don't use alcohol to clean off the site. You use betadine or, yes, spit. You take some of the patient's own, that they take their rye whiskey out of the back, splash it on them. And then this is the voluntary blood draw consent. And so you can draw it at that point and give it to, and even if the person is not a patient, but as long as they're under arrest and they're voluntarily consenting. Now we're working with the local police who would like, if they don't voluntarily consent, if they don't voluntarily consent, it tells you that all sorts of bad things will happen to you. Like you'll lose your license, your children will have to work for nothing for years. It goes on and on and on. So I'm not really sure what part of voluntary I understand in this, but if they don't volunteer, the tendency is that they're going to take them to jail and get a judge's warrant for a search warrant, which is basically says, you will give us blood. You don't have a choice. Now, the question is going to be how that's going to be done and whose responsibility that is, and I'm working that out with the sheriffs and the police. Because we, in many cases, some of the local agencies said, yeah, we'd send the medic there to the jail to draw blood rather than have to take the person all the way up to, let's say, Longview. We'll draw the blood at jail if there's a warrant, but we can't do it. We have to do it aside of our 911 activity. So if somebody, if you're going to the jail and you have an emergency come up, you end up going to the emergency first. So we'll have to work that out. Okay. So we will give you clear instructions, but we will provide that stuff for you that you can, if you have a legal, if they give you a legal request, you can draw blood and you have immunity from the patient cannot, the person cannot say, hey, they drew blood on me, they assaulted me. No, that doesn't work. You are protected. But I want to be very careful and not have to, have you. Where are we today, Mark? Yeah. Woo. All right. I got it. Okay, a couple of case reviews. Priority 5 on unconscious. That was what we dispatched it. On arrival, found patient in mother's arms standing in living room. Yes, folks, this is an ALTI we're going to talk about. Patient is a 3-month-old male. Patient weighs 13 kilos. Chief complaint, patient slow to arouse from sleep. No recent illness, no recent behavioral abnormalities. Mother relates she put her son down for a nap, and when she went to check on him, he didn't respond. She picked him up again, and again he didn't respond. She relayed this lasted about a minute before he began to respond to her and then acted totally normal. So that's an ALTI, an event that scares the person. On our arrival, patient seems alert and responds to our evaluation by crying or sucking his thumb. Mother relates patient never stopped breathing but may have been a little bit more pale than normal. Color change when she first picked him up but didn't say with any certainty. Mother also denies fever, any recent medical problems. Relates the only medication the patient has ever received has been occasional periodic Tylenol. Doesn't remember when the last time was the child got Tylenol, but wasn't recent. Temp 97.6, pulse 136, respirations 28, skin's warm, dry, and pink. Lungs are clear, abdomen supple, good muscle tone. When asked if the patient had been unattended or left in anyone else's care recently, patient stated they've all been home all day. Patient's always been with them. Advise family that we should transport via ambulance for evaluation of ED, but mom and grandma insist on taking patient to their pediatrician. Recommend that we call pediatrician directly. This is before we had the protocol. Recommend call pediatrician directly while on scene to ensure that they do or don't want the patient taken to an ED instead of their office. Patient denies that, insists they would just transport patient to the ED themselves. Patient mother signs refusal of transport form. Well, this kid never got to the ED, never went to the ED that day. He had been in the ED 8 days old with a brief episode of wheezing when supine. Thought the only thing they noted was that the parents did smoke. The family had reactive airway disease in the family. They probably gave them grief because they smoked and probably didn't want to go back to EDs again. But he was sent home from that at 8 days, and ED care was perfect up to the point, and we've now added to the protocol that medical control concurrence for leaving a patient. We don't know what happened to this kid since. I don't think anything has happened as far as we know, but this is the kind of case that that may turn out to be a problem in the future. It'd be interesting to see if it pops up again. We know where this kid lives, so we can keep an eye on that. But that's a simple ALTI. I think the outcome is probably okay, but should have had medical control concurrence to leave at home. Case 2. It's an adult dispatch on a cardiac respiratory arrest. Patient's friends were present and related. Patient was standing in his living room when he suddenly collapsed. Friends say the patient was not breathing, had no pulse that they could find. He had they didn't think that the patient had any complaint of chest pain or a difficulty. He's been under a great deal of stress. It's a past history of atrial fib, aortic stenosis, diabetes, angina, hypertension, hypothyroidism, and a triple bypass 10 years ago. 69-year-old male on arrival, laying supine on the floor with patient's friends attempting to perform CPR. Was he getting telephone instructions too? I think. Patient was pulseless and apneic, airway clear, head and neck purple. Arrested patient's skin was pale, warm, and diaphoretic. Pupils were fixed, trachea was midline, abdomen was soft, patient's neck and back intact, extremities intact. Primary assessment was done, CPR was taken over from bystanders, cardiac monitor turned on, and defibrillation pads attached. OPA placed, ventilate patient with BVM, IO established, rhythm check, VFib, defibrillate patient, continue CPR for 2 minutes, epi given in that time period. Rhythm check, patient had ROSC with palpable radial pulse. 12 lead obtained, ST elevation to multiple leads. Package patient for transport. While packaging patient, cardiac rhythm returned to VFib. Defibrillated number 2, started CPR for 2 minutes, gave ALPS 1A and 1B. Hurrah, hurrah. And that was the next 12 lead. Rhythm check, patient had ROSC with palpable radial pulses. Initiated transport, IV started. IV was now started in the left antecubital, given 400 cc's of normal saline total, began breathing on his own, had gag reflex, OPA was removed, ETCO2 placed, cannula placed on patient, reassessed patient during, he get gradually better. Upon arrival, medical center patient was speaking while being transferred. This is actually Marty Bell's summary of the case. And did you take care of this patient?
Yes.
Yeah, it's even better.
Both of the arrests I did.
Ah, you're the cardiac doc. So he had known severe ischemic cardiomyopathy, but he did not have an ICD originally. Argument might be that he's kind of the patient who probably should have had a implanted defibrillator. At any rate, so he was defibrillated, he got his ALPS drugs, 1 and 2, A and B, and initially obtained him more and more alert. He was confused, wheezy, improved with bronchodilators and brief BiPAP.
It was just a brief time that he was on BiPAP that really improved his mental status, respiratory status, stable.
Now, he had his second 12 initial EKG.
He was hypovolemic, though. It was, I can't remember exactly
Right.
what it was. It was low, just 90.
And it had to be really low to get intravenous potassium. So put on an amiodarone drip. The cardiologist did not take him right to the cath lab, even though he had a 1 millimeter ST elevation in 3 and F, for a couple of reasons. Because he had severe aortic stenosis, he also had cardiomyopathy. His troponin peaked out at a 22, so he had some myocardial damage. He was stable on the drip. His INR and kidney function were elevated, so he wasn't taken right to the cath lab. He needs to get his echo showed him he had severe ejection. He had an ejection fraction of 20%, which is really low. So he needs to have a implantable cardiac defibrillator to keep him from having another episode. But this was really good job and really following all the resuscitation plan by fire crew and AMR crew, and then getting the patient rapidly in for other stabilization. But they did a great job. So we will probably have a little trouble following up with the Kaiser stuff because he was a Kaiser patient. But hopefully he's had an ICD implanted.
Yeah, maybe it's a follow-up.
Yeah. Right. Here's a response. It was sent out code 3 for a possible cardiac arrest on a 7-year-old. On arrival, find the patient in a grand mal seizure. So, patient had been incontinent, no past history, no recent illness or trauma, never had a seizure, acting normal in the morning. Her AV-POO was unresponsive on all. She was given midazolam, 25 milligram IM. Seizure did decrease but didn't terminate. Vascular access was gained, blood glucose was normal, vital signs, her GCS was still 3. She got another 2.5 of midazolam, and now it says seizure terminated. Although they do note down here that her eyes were somewhere I found eyes were deviated. At any rate, she remained stable. She still had she ended up with a Glasgow Coma scale of 6, improving slowly, and now reacts to pain. Ultimately had complete termination of the seizure, transported code 3. She was given more sedation, initially flaccid on the left side with discontinent gaze to the right. Basic rule is you look toward the lesion and look away from the seizure focus. But I would argue that if she has discontinent gaze to the right, that may still be a seizure, or at least extremely postictal. Now, did you take care of this one?
No.
Okay. So she was given, so the hospital report, she's afebrile, non-toxic appearing. She continued to improve in the department with no seizure recurrence. Labs and imaging, including CT head, were all normal. Patient was discharged to follow up with the PCEP for outpatient MRI and the EEG. Since all the ED data was unremarkable, postictal confusion had totally cleared by time of discharge. So this is a first onset, new onset grand mal seizure, probably heralds underlying seizure disorder, but needs to have the pediatric neurologist work that out. So good stabilization, good evaluation by the crew. I appreciate giving her repeated doses of Versed rather than one big one, and making her totally gorked out or respiratory depression. She was checked to be sure she wasn't hypoglycemic. All the things went well. Now, this is a motor vehicle. 2 patients, or multiple patients, 2-car motor vehicle. The patient we're concerned about is a 26-year-old male, unrestrained passenger of a 4-door sedan traveling at high rate of speed, rear-ended an SUV, and then came to stop against a fence. Unconscious, unresponsive upon arrival and for the duration of the call. Lying supine in the back of the vehicle with snoring respirations. Airway is adequately patent, however, there's bloody secretions. Top palate of mouth is totally deformed with a possible Lefort-type fracture. Breathing shallow, snoring with occasional grunts. Lung sounds present in all fields. Right pupil dilated compared to the left. Starring on windshield where patient is sitting. No airbag deployment. Passenger seat broken and mangled. Laceration to left shin with no active bleeding. Spinal precautions are done. Suction blood in airway with the Ankower type of suction. Got oxygen. GCS is 3. Lung sounds clear. Vascular access was done. Vitals, blood pressure 96/70, pulse 100, pulse regular. Now, they didn't, because they were able to adequately maintain oxygen saturation. I don't see I don't see a CO2 noted, and because of the airway, the upper airway, the mouth deformities, the palate deformity, they elected to transport, maintaining ventilations and maintaining just a BVM type of thing rather than to intubate or attempt intubation with this. This was a morbidly obese male who was intubated orally in the ED with a trauma surgeon standing by to do a crike if that was necessary. This was done with